Okay, good afternoon and welcome everybody to what I think promises to be a very interesting and exciting hour looking at the ambulatory monitoring of arrhythmias. Oh, just lost my slides. Can people see the slides? Sorry, they've just disappeared. Wonderful. Hi, good afternoon everybody. Welcome to what promises to be a very interesting hour looking at arrhythmias and how we can impact the challenges of CVD. I'm Breed O'Brien. I'm currently the Deputy Director of Digital Health at NHS EI, what used to be NHSX, part of the Digital Care Models team. And I'm currently leading a programme of work that is around supporting people at home using technology to support people with long-term conditions to manage their health, or people who obviously may need other levels of care to be looked after at home in virtual wards, etc. But actually from the 1st of April, I'll be taking over a new role as Director of Innovation, which will be looking at how we use digital within the CVD pathway. So I'm particularly interested and excited about what we're going to hear from Trudy and Matt this afternoon. Yes, okay, wonderful. We're back. So how can technology support? Very apt, really, isn't it? So cardiovascular disease and how can technology support? Well, first I thought it would be worth reflecting on the long-term plan and the commitment to really deal with this, what is a very significant health challenge. And obviously for the purposes of today, we're going to focus on arrhythmias and atrial fibrillation, but we've also been doing lots of work on how technology can help with blood pressure management and high cholesterol. So it's been in the long-term plan, it's a commitment, and we're probably have lost some time with COVID, but we're now in a place where I think we've got a wonderful opportunity to move this agenda forward. And I probably don't need to speak to a lot of people who are on here today about the case for change, but if any doubt, we've got 6.4 million people living with CVD, responsible, I think this is quite a shocking statistic, responsible for nearly 25,000 deaths. And I listened recently to one of the national clinical directors speaking about this, and he said something like, the same number of people a year die from CVD that died in the first year of COVID. But actually, we've sort of accepted that. So I think there's a real challenge here about how we move this agenda forward rapidly. Obviously, huge financial benefits, both to the health service, but to the economy more generally. And we know that there are lots of incentives around COAF, etc., to help drive this agenda forward. And we also know that actually people impacted by this are often those from ethnic minorities or from socially deprived communities. So again, a really important perspective in terms of equality. And interesting that actually we also have, although this is such a problem area, we also have a lot of people who aren't turning up for outpatient appointments. So there's a question for me in terms of, how do we move from perhaps a paternalistic model of care to one where patients are, or people are more enabled to look after themselves and perhaps come when it's important to them rather than as a matter of routine. So just a very quick view of some of the technology opportunities across cardiology. As I said, we've been doing quite a lot of work on blood pressure at home, supporting that to date. But that's obviously a component part of the ABC of the commitment for CVD. And some of in the pre-hospital part of the slide there, you can see some of those are things, platforms that help manage appointments, prescriptions, electronic patient records, but also you can see one of the focus areas of today, people are using AliveCor in this particular, in the pre-hospital stage. And then we've got when patients move through hospital, post-hospital, what technology may be around to help and support people. And I'm sure Trudy and Matt will talk about some of that. But I just wanted to talk about what's happening now, what's planned, and where we think the opportunities are. So again, blood pressure at home, 100,000 blood pressure monitors distributed across the country, and really some really good learning about how this is helping people to take more control and feel like they're able to manage things differently. But this is just one part of the problem. So yeah, blood pressure management is really important, but we do need to look at the broader perspective. So we have plans to continue to scale up the blood pressure monitoring program with evaluation, so we understand the impact, but also with an eye to where the other opportunities are. So looking to prototype some new models of care and looking at how technology can assist. So things like, we know, echocardiogram is a big waiting list challenge, diagnostics generally within this pathway, but also what's the opportunity that remote monitoring can help with. And I actually have an AliveCor device on my person from where I used it with my mother-in-law who was newly diagnosed with AF during wave 1 of COVID, and we managed with her GP to titrate her meds without having to go in to the GP surgery. Well, she couldn't go into the GP surgery. So I've seen the impact of some of this personally, but also really important that anything we do that we're evaluating and learning from this. And obviously from a perspective of the AliveCor and the monitoring, Matt and Trudy will speak to, no doubt, to the NICE approval, the recent approval that really moves this agenda forward in a way we haven't had before. But I just wanted to finish on a patient perspective. Although it's about blood pressure at home, I think the key of any of this from a technology perspective is how it's user-centered, that it's easy to use, that it actually is convenient for patients, and that also it's something that actually fits in with their life. We also have supported with people with a serious mental illness, have a life expectancy of 20 years less than other people, and need to be on, some of them need to take antipsychotics, and a side effect of antipsychotics, there is a cardiac side effect. So we've got people across the country using the devices to measure QT prolongation. And actually speaking to a psychiatrist recently about how they've used this, he talked about being able to use the device with a patient on a park bench to be able to start the medication really quickly. Now that tells me that this is something that's really easy to use. So I'm going to stop there with leaving you with the usability and how this really needs to be easy for patients, and hand over to Trudy. Trudy, just check for your slides to come up. Trudy is the CEO of Arrhythmia Alliance, and she's going to take us through her view of this. Over to you, Trudy.
I am Trudy Loban. I'm the founder of Arrhythmia Alliance and the AF Association. And we've done an awful lot of work using digital technology in the detection of various arrhythmias, and specifically on atrial fibrillation. In fact, without digital technology, we certainly would have missed a lot more people walking around with AF previously unaware of it. So I will begin my slides. So this presentation will cover a little bit on the long-term plan, although Brie has already covered that. The AF disease state overview, the current standard of care for ECG ambulatory monitoring, a little bit on AliveCor KardiaMobile technology, of the use of that and other digital technology, but the simple use, that's what I think is so important when you're engaging with the public. And also quality of life and living with EF for the patient. We mustn't forget the patient voice and how important it is to include them. We can come up with wonderful digital tools, medications, all sorts, but does it actually help the patient, and does it help or lead towards improving their quality of life? And what do the NICE recommendations mean for the patient? I've mentioned Arrhythmia Alliance, which is a coalition of charities, patients, caregivers, healthcare professionals and allied professionals. We work together in collaboration to improve the diagnosis, the treatment and quality of life for all those affected by arrhythmias. Atrial fibrillation was founded because of the demand to AA from people with AF, and there were no other organisations at that time focusing on AF. So we're a sister charity of Arrhythmia Alliance, raising awareness of AF by providing information and support materials for patients and medical professionals involved in the detection, the diagnosing and managing atrial fibrillation. And we do that under many different campaigns, but detect, protect, correct. Detect AF with a simple pulse check and a 1-lead ECG. Protect against AF-related stroke with access to anticoagulation therapy. Please remember, anticoagulation is not a treatment for AF. It is a therapy to help reduce blood clots forming and traveling to the brain, causing an AF-related stroke, and correct the irregular heart rhythm with access to appropriate treatments. And if we detect, protect, and correct, we will perfect the patient care pathway, restoring the patient back to a person, hopefully. So Public Health England, 10-year cardiovascular disease ambition for England, and ABC, very easy to remember, atrial fibrillation and reducing the number of AF-related strokes. We need to say AF-related strokes because it's not all strokes, and not all strokes are cardiovascular related. So AF, blood pressure, cholesterol, ABC, and how digital technology can help with that. But obviously for me, my focus is on atrial fibrillation. So AF, it's estimated that there are more than 500,000 people in the UK, over 500,000, with undiagnosed AF. That's a lot of people. And without preventative treatments and therapies, approximately 1 in 20, so 5% of them, will have an AF-related stroke each year. AF-related strokes are known to be more devastating, more debilitating, and in many cases fatal, more so than any other stroke. And yet the majority can, could, should be avoided if only we could detect AF quicker, easier, sooner. So a very brief study carried out during the pandemic in Denmark, during a 3-week period in lockdown, there was a 47% reduction in the diagnosis of new AF. A UK study reported a 43% reduction in the rate of diagnosis of cardiovascular conditions during the first 3 months of the pandemic. And the same study reported between 29 and over 50% reduction in first prescriptions of CV medications over the same period. Further studies are going on. We're only just coming out of the pandemic, and we know that, unfortunately, like cancer, there have been many more cardiovascular deaths and many more strokes, and in particular AF-related strokes, that have left people permanently disabled, or they have died due to the pandemic and not being detected and diagnosed. Digital technology can help. It can't do everything, but it can certainly move us quickly along the road to getting a diagnosis and management. I'm a positive person. I try to see positivity. And I think one of the positive things from this dreadful pandemic, and there aren't many, but digital technology has leapt forward. Some people say 10, 15, 20 years, and I agree with them, because look at us now on this webinar. We wouldn't have done this prior to the pandemic. We would have all made our way to London or some other city to sit in a room and listen to the speakers. Whereas now, from the comfort of our homes, our offices, etc., digital technology has enabled us to have far greater access to medical experts and for healthcare professionals to learn and also to revisit, because all these things are recorded, and for patients to access information and education. And we are a generation of digital. Yes, it might be that the younger people use digital more often, but actually, when you look at it, it's relatively evenly distributed in each age group. I know in the US, grandparents are way ahead of their grandchildren with digital technology. Some say because they've got the time to sit at home and research and learn about it. I think now, because of lockdown, many more of us have caught up with that because we were all at home. We didn't have a choice. We had to learn about it to be able to continue working from home. So digital technology was around pre-pandemic, but it really has been launched far, far further into the field. And that's fantastic. It's fantastic for the person possibly living with symptoms, not knowing what it is, can't get to see their doctor because of the pandemic. For the patient with symptoms, remember, a person isn't a patient until they're diagnosed. Knowing what's wrong with you, beginning to get treatment is the most important thing. So yes, there are blood pressure monitors that can detect AF. There are even rings and patches. We've got the watch, and we've got devices such as AliveCor Kardia. Now, I was aware of AliveCor Kardia before it even came to market, and we carried out a little study by ourselves, nothing to do with the company, but we did manage to get some donated. Everyone that used it said how simple it was and how reassuring. Only one person out of over 1,000 returned it, saying, oh, it worries me a bit because I don't understand the wiggly lines. Everybody else found it reassuring, and it's good to get that feedback. And as Bree said, it's so easy to use. The Apple Watch is very good. However, you have to have the watch, you have to have an iPhone, and for many, it's beyond their financial reach. And the other devices, such as the patches, etc., obviously have to be prescribed by a healthcare professional, and that might be the next stage. They all have a role to play in the detection and the diagnosis of AF and other cardiac arrhythmias. Arrhythmia Alliance and AF published our AF white paper, Putting People First, and it highlights the prevent, protect, detect, correct to perfect model, and importantly, the role that technology plays. We also, since 2011, have been hosting Know Your Pulse events. Know Your Pulse to know your heart rhythm. It could save your life. We're not there to diagnose. I'm not a doctor, can't do that. But we are there to make people aware of their heart rhythm, not just their heart rate. Many people say, oh yeah, it's 63. Well, that's good that they know their heart rate, but is it regular? Some people say, oh, it's that one figure over the other. No, that's blood pressure. Good that you know your blood pressure, but we need to know heart rhythm. So we teach them how to take a manual pulse check, and then we use digital technology. And it's so simple with the devices such as AliveCor because they're so mobile. People can use them anywhere, and they can possibly detect AF. With the possible AF, it means you can give them a copy of their one lead ECG. They can email it to themselves or to their doctors, and they have the evidence that something was irregular at the time of using it, especially for people in paroxysmal AF, where they don't always have symptoms. So it's something that can be captured if they're feeling the palpitations, whereas they make an appointment with their doctor, it may be that they're not in AF when they actually have the appointment. We also published the AF Pioneers Healthcare Report showcasing best practice. We've been doing this since 2011 as well, and many of our cases there are about digital technology. So all these reports and posters and information are downloadable from our website or to contact me to help get the message out and to help not just the people, the patients, but also healthcare professionals on embracing digital technology and how it can actually save the NHS money, but more importantly, identify somebody with a condition and get them diagnosed and treated sooner. So one of our schemes, I mentioned that we had Know Your Pulse events, but of course those all stopped when the pandemic came along and we were all locked down in our houses. And then along came the vaccine. And fortunately, some of our GPs could see an opportunity here, which I fully embraced. So somebody's coming in to have their vaccine, they have to stand in line. They have to give their details, add an extra box. Would you like to have your pulse checked and a one lead ECG? You have their consent. In some places, they used AliveCor because it was so easy to sanitize. And they had it while they were drawing down the vaccine. They asked the person to put their fingers on the AliveCor for 30 seconds. The important thing was not to delay the vaccine rollout. And of course, as we were being called through in our age groups, we saw a higher incidence of AF in the older age group, but surprisingly more than anticipated in the younger age group as well. For some vaccines, you had to wait 12 to 15 minutes after you had it. So some centres then offered using AliveCor whilst you were waiting. And again, one volunteer could sanitise, just like they were sanitising the chairs you were sitting on. It wasn't adding any extra layer. And yet, amazingly, it was finding previously undetected AF. So an example of this, a GP surgery in Suffolk, 317 people were screened using the single lead mobile ECG in one day. I don't really like to use the word screened because screen hasn't been approved by the National Screening Committee. So they were offered. 26 were found to have possible AF. As I say, we never diagnose. That's for a doctor to diagnose. And 20 of those 26 had not previously been diagnosed with the condition. Subsequent to this, at a medical centre in London, 7 of 160 people in one day had possible AF. So overall, that means 6%, that's 27 of all those that took up the offer of 477 had previously undetected possible AF. I think the national prevalence is claimed to be 1.8, 1.9, maybe 2%. In all the Know Your Pulse events that we've hosted, in hospital receptions, in Tesco car parks, in pharmacies, schools, even in Times Square in New York, we are always up, normally about 8 to 9% prevalence. So I'm not surprised at this 6% at all. Doctors welcome it because when a patient then goes along and says, I was having my vaccine, I had my pulse checked, I had some digital technology, and it says I've possibly got AF, and you know, doctor, I've been coming with palpitations, or I didn't know I had any symptoms, there's evidence to show the doctor. And I will give a case study at the end of this, the importance of having that evidence, not just for the patient, but it also helps the healthcare professional as well. So it's fine having all these talks and all these webinars, but what about the people living with it 24/7? How do they feel? So on the left, those are my parents, my mother and my father. They both have had AF. They both have had bleeds. They have both had AF-related strokes. And sadly, my mother died last May from vascular dementia brought on by AF. My father is going to be 96 in May, still has his AF, but he's anticoagulated and he's now being cared for 24/7 by family. Hopefully, you know, he will be okay. When he had his AF-related stroke, it was when my mother, at the beginning of her dementia, he lay on the floor for hours, despite him trying to call her. And all she said was in the morning, why didn't you bring me a cup of tea? So the impact of an AF-related stroke, after that, they went to live at my sister's. They could never be left alone. And AF did that. Now, if we look at a husband and wife on the other side who moved to a new area, happened to be Suffolk, they were due to have their vaccine. They happened to be registered at that surgery I mentioned in the previous slide. They both agreed that they'd like to know how to take their pulse and have a one-lead ECG. They both were in AF. So the GP, who's one of our medical advisors, sent them off for a 12-lead ECG. He could see what was on the AliveCor Cardia, but without seeing them, he sent them for a 12-lead. So they waited several weeks. They had a 12-lead. The 63-year-old husband, yes, he has AF. So he was diagnosed. He was put on anticoagulation. The 61-year-old wife wasn't in AF when she had her 12-lead ECG. So when that came back, the GP, because they were new to the practice, he didn't know them. He's very supportive of our initiative. He was reading through her notes and he found that she'd had a cryptogenic stroke 6 years previously of unknown cause. So he called her back in. He took a manual pulse check while talking to her. And surprise, surprise, she was in AF. It just goes to show that whether it's a manual pulse check, a 1 lead or a 12 lead, if it's paroxysmal, you need to catch it when it's happening. And the good thing about digital technology such as AliveCor, Kardia and other devices is the patient could have that at home. They could have it anywhere and they can capture their symptoms. She's now anticoagulated and hopefully will never have another stroke. But it shows the difference with digital technology. And although NICE says you should all go and have a 12-lead ECG, for some, when it's obvious they're in AF, I know many doctors are saying, we don't need that layer. We don't need to delay anticoagulating them. We need to get them anticoagulated. We need to reduce their risk of AF-related stroke and tick the box for the long-term plan to reduce the number of strokes. So with the patient experience, we need to detect with a simple pulse check. Using digital technology is perfect because you have the evidence to then show your doctor, and that helps your doctor as well as the patient. Protect against AF-related stroke using anticoagulation therapy, not aspirin, because surprisingly, some patients are still being given aspirin, even though it's not recommended for reducing AF-related stroke. Correct the irregular heart rhythm with access to appropriate treatment, and then we will perfect the patient care pathway. And please remember, no one chooses to become a patient. By working together, doctors and patient organisations can support the patient back to a person leading an active, healthy life. And we have to remember the current standard of care, which I've mentioned, the manual pulse palpitation, perform a 12-lead ECG, etc. This is all what's in NICE. So I would definitely say, yes, if you can't capture it, go and have those 12-lead ECGs. But remember, it doesn't always get captured on a 12-lead either. And to use digital technology and for patients to be able to take it home or to have it at a low cost that they purchase it themselves, then they're helping themselves, they're helping the NHS, and the NHS will be helping them too. There are huge challenges waiting for a 12-lead ECG, the long wait time. And of course, that's even longer now. I know of 2 areas where in the south of England, there are 2,000 people waiting for outpatient appointments in the cardiovascular clinic. And in another area, there's a 9-month wait list. That's too long for someone living with undiagnosed AF. It's a ticking time bomb for an AF-related stroke. And equally, the day that they get called for their 12-lead ECG, if it's paroxysmal AF, it may not even be detected after all that wait. For some, it's discomfort. It requires face-to-face consultation. A Holter monitor, for example, has a low diagnostic yield. And there's turmoil of no diagnosis and repeat appointments with huge waiting times. And for the GP, it's seeing that person over and over again. It's taking up the GP's time and valuable appointment time. It's taking up the person's time. And yet with digital technology that they can have at home, all of that can be cut out. And importantly, they can receive appropriate anticoagulation and treatment. So there is no time to wait. AF-related stroke could strike at any time. And we raise awareness. We have our Global AF Aware Week, making up for lost time later this year. All of these things that I've mentioned in my presentation are available to download or to contact me if you'd like more information. And finally, the NICE recommendation. What does it mean for the patient? AliveCor Kardia is now recommended as an option for detecting AF, which is a fantastic breakthrough. And that's the other thing. If you're recommending to patients or patients contact you saying, I've seen this app, I've seen this and that, should I get it? It's important that they understand and to have an app or a device that has got regulatory approval. So Kardia has now got that, and it can be recommended as an option with suspected paroxysmal AF who present with symptoms such as palpitations and are referred for an ambulatory ECG monitoring. In fact, it's the first and only NICE recommended ECG device for detecting AF. So it's a fantastic step forward for NICE. It's a fantastic step forward for the patients that finally something has been approved. It's wonderful for the doctors and, of course, the company, but importantly, it is the patient and speeding up that detection and diagnosis. And this is what digital technology can do. And it can help everyone, from the person with undiagnosed symptoms, the patient, the caregivers, the healthcare professionals, the NHS. Thank you.
Thank you, Trudy. There's a question in the chat, but we'll come back to questions at the end of Matt's presentation. Can I just encourage people to pop their questions in the chat? Lots of food for thought there, so I'm sure we'll have a good discussion. If I can pass over now to Dr. Matt Reid. Matt is a professor in the Royal College of Emergency Medicine and a consultant in emergency medicine in Edinburgh. Over to you, Matt.
Thank you ever so much for the invitation to talk at this webinar this afternoon. As Breed said, I work in Edinburgh, and I'm going to, during the course of the next 15 minutes or so, talk to you about our experience of using the AliveCor device in Edinburgh. So here are my disclosures. I'm going to talk about the iPED study, and this was funded by Chest, Heart and Stroke and British Heart Foundation, and didn't receive any support from AliveCor. So I'm going to discuss a little bit about the problem, and Trudy has already talked a lot about asymptomatic AF and the risk of stroke attached to it, and how the AliveCor is able to detect asymptomatic atrial fibrillation through a screening type model, as in the excellent example of the vaccine clinics. I'm going to talk more about symptomatic arrhythmias and symptomatic detection of symptomatic atrial fibrillation. We know that patients presenting with arrhythmias can either present with syncope or with palpitations. They're the two commonest type of presentations. And in order to detect the underlying cardiac arrhythmia in syncope, we need to be constantly monitoring somebody. However, with palpitations, we need some type of event recorder device, so the patient doesn't have to be conscious. In palpitations, the patient is conscious, whereas with syncope, the patient has a blackout and loses consciousness and isn't therefore able to activate something. So that's why we need a continuous ECG monitor. But with palpitations, the patients don't lose consciousness, and they're able to activate an ECG recorder to record the ECG while they're having symptoms. So I'm going to discuss a little bit about the problem. I'm going on to talk about the iPED study and how we then incorporated this into our NHS loading pathway. I'm going to talk about our experience over the last year with this pathway, and finally talk a little bit about the MTG report, the NICE report, and what it means for physicians. So palpitations, symptomatic potential arrhythmia. It's very common. See almost 1/3 presentations to EDs across emergency departments across the UK, and it's a very common presentation to general practice as well. Determining what the underlying rhythm is difficult because, as Trudy said, we need to capture an ECG at the time of the symptoms, and this is the problem. 12-lead ECG and conventional monitoring are unfortunately of limited efficacy here because in many patients the symptoms are very infrequent and don't occur while they're in the emergency department, while they're in their general practice, while they're in the back of an ambulance, and therefore they're not able to record an ECG. And because of that reason, Holter monitors at best have a yield of around about 20%. So the AliveCor device, I have one with me here, so recording my ECG, shows that the, oh, that's not going to work. You have to take my recommendation for that it's now recording my ECG. And the idea behind it is that the patient's out and about in the supermarket, for example, they get an episode of palpitations. They can reach into their handbag or wallet, they can grab the AliveCor device, they can sit down and they can measure their ECG for 30 seconds at the time that the episode is actually happening. And they can capture it on the phone using the device. And they can either email that to their GP or physician or whoever's looking after them in the hospital, or they can take that along to the practice and show them, this is what's happening. This was my ECG while I was having my episode, and they can, at that point, be diagnosed. So with that in mind, I came across the AliveCor device several years ago, and I thought about the problem that we have in the ED, and that we just really can't offer these patients anything else before this, apart from telling them to go to their GP surgery. Obviously, many surgeries don't have access to ECGs. We could ask them to phone an ambulance. The health service is obviously at extreme pressure at the moment, but sometimes that's the only way, if they were having palpitations, to record an ECG, or we can tell them to represent to us. However, commonly the symptoms are settled by the time they come back again, and this is a repeated cycle of us not being able to record a diagnostic ECG. So I felt that this device would be absolutely perfect for these type of patients. And we set out performing a trial. This was a multi-centre trial across the UK of 12 UK emergency departments, and we randomised patients to either having the AliveCor device along with standard care, or to receive standard care alone. We enrolled 243 patients. There were slightly more females than males. And as you can see from that little diagram at the bottom, a real broad spectrum of patients. And as Trudy said, this technology is still able to be used by the older age group. So we've recruited a reasonable number of patients in their 70s to the trial. Most of them presented with palpitations. So the headline figures, we found that after 90 days, we found that patients who use the device were 6 times more likely to record a symptomatic rhythm during that 90 days than those who were not using the AliveCor and they were just having standard care. What type of rhythms were we recording? Well, it wouldn't surprise you to know that about 85% of these symptomatic rhythms were what we would say were benign rhythms, so sinus rhythms, sinus tachycardia, and ectopics. And these are equally important to detect, because if we can detect a symptom rhythm correlation in these patients, we can reassure them that while they're getting their palpitations, their heart is recording a normal sinus rhythm or a normal sinus ECG that doesn't need further management apart from education and advice and reassurance. Around 15% of patients, we found that we were picking up atrial fibrillation, atrial flutter, and SVT. And obviously this is important because these patients need some primary prevention in terms of stroke risk, and may well need some treatment in terms of ablation, for example, for their SVT or medication. And this distribution of normal rhythms and cardiac rhythms is found in research across the world into palpitations. This is a similar kind of a detection rate of those two types of rhythms. We also looked at the time to record a symptomatic rhythm, and those that were in the intervention group using the AliveCor recorded a symptomatic rhythm in about 10 days compared to almost a month and a half in those who were receiving standard care. This is a chart, graph, survival risk chart showing patients as they're going through the study. And you can see that early on, we're using the AliveCor. So the blue band is those that were using the AliveCor in the intervention arm. You can see that we were rapidly at the beginning, in the first 20 days, making symptomatic rhythm detections. Whereas in the standard care group, this slowly trickles down across time. And this is as standard care starts to kick in, with maybe a few being picked up with 24-hour tapes, or patients having other types of monitors. Over the course of the 3 months, slowly patients were starting to be detected. So you can see there's a big time duration between those that were being picked up with the AliveCor and that extra worry in those that are requiring longer to be able to detect the rhythm. We looked at cardiac arrhythmias specifically. So this is the atrial fibrillations, the atrial flutters, the atrial tachycardias, and the SVTs. We found that in the intervention group, we picked up 11 of these, and in the control group, only 1. And this is a randomized controlled trial, we can safely say there were, at the end of the trial, there were probably around about 10 patients who had, in the control group, who had yet to have their cardiac arrhythmia detected. We found a cost-saving benefit, and again, this was mainly related to investigations that were of no use in the control group, repeated investigations. Patients liked the device, they found it easy to use, and had no problems in being able to use the technology. So on the back of this, we set up the ambulatory smartphone palpitation service in Edinburgh. The QR code on the left gives you a link to our algorithm. And essentially, this is based in our ambulatory care service, which is part of our acute medicine service. And patients who are seen in the ED or in acute medicine as emergencies are brought back the next day. And as with syncope, there is some evidence that the likelihood of picking up the underlying rhythm in those presenting acutely is earliest in the first few days or first few weeks afterwards, rather than 6 months down the line. So we have a window where we have a better opportunity to pick these up, and therefore they come back the next day, they're assessed, they're fitted with the device if it's appropriate, and they're sent away again with the device. The reason we don't apply the device within the emergency department is in the slightly, but not that quieter setting of the ambulatory care clinic. There's a little bit more opportunity for one of the team there to talk through the patient how to use the device. Although obviously a model where it's given out in the emergency department could be possible. This is the time to detection in the iPad study of those patients who were using the intervention device. And you can see that 93% of patients recorded a symptomatic rhythm within the first 28 days, although they all had the opportunity to use it and had it for 90 days. So we decided in our clinic to better use efficient device usage and enable timely treatment to bring people back at 4 weeks. If they hadn't recorded a rhythm at that point, they were sent away with the device for longer until they recorded a rhythm. And obviously we could re-review them once they did that. But this allowed us a better turnover of devices. So what was our experience with the clinic? So between 2019 and 2020, we fitted 237 of 290 patients who were referred to the clinic. And of those, we made a cardiac diagnosis in 17. And we made a symptomatic rhythm correlation that was sinus rhythm, sinus tachycardia, ectopics in 200 patients. What were the cardiac diagnoses? Well, again, as with the iPad research study, we're demonstrating that in the context of actual practice, that the rhythms we're picking up are just the same, with 10 episodes of atrial fibrillation and 5 SVTs and a few other rhythms there that were detected. This was one of the patients who took part in our study, a patient PM who had had a previous episode before she was enrolled in the study of palpitations whilst out walking her beautiful greyhound dog. And about 4 weeks later, she was having lunch in the middle of Edinburgh with a friend at a cafe and started to get fairly bad palpitations with pre-syncope and felt really unwell with these palpitations. So an ambulance was called. She came to our emergency department and she elected to take part in the AliveCor study and was randomized to getting the device. Unfortunately, because of the effect these 2 episodes had had within 4 weeks, she was at this point that she wasn't feeling comfortable going out walking her dog, who she used to walk every day. She was hugely anxious about getting another one of these episodes while she was out and having no one around to be able to help her out. However, within 3 weeks of having the device, she recorded an episode of atrial tachycardia, which several weeks later she underwent ablation, and since then has had no further episodes and is back to normal, has no further anxiety, and is out walking every day with her dog. So I've obviously presented how we use the Cardia device within our emergency department, acute medicine unit and ambulatory care setting. However, this model is equally applicable to a whole lot of other settings and scenarios. There's no reason why general practices can't have several devices which they lend out in a similar type of way. The arrhythmias we're detecting in palpitations are, although associated with morbidity, are not rhythms that can cause immediate sort of cardiac arrest, for example, like with syncope, where we worry about detecting episodes of ventricular tachycardia, ventricular fibrillation on these devices and not being able to intervene. Patients don't need immediate intervention a lot of the time. So there's no reason why they can't be given out some practices, and GPs can look at the recordings they get back and then make onward referrals. And not all of these patients need to be referred on to a cardiologist. Clearly, if you've got an SVT that you want consideration for ablation, you will need to be. But these patients who have atrial fibrillation detected, primary prevention can be started through GP surgeries. They can be CHAD-FAST, risk-ignored, and started on anticoagulation if appropriate. Also can be started on rate control medication. They can be hosted within pharmacies, so or in certain places where people know if they're out and about and they get symptoms, they can go somewhere and get a recording made there. So obviously flexible, the devices, they can be used in a whole lot of other settings. We have only opened our clinic at present to acute presentations because obviously the large number of patients we would be referred to through general practice at the moment, which we at the current time don't have any funding for doing. And what we are starting to do now as well is, if patients haven't recorded anything, they, rather than coming back to the clinic, they'll just phone us up and they'll keep the device for a bit longer. And AliveCor do have a dashboard which you can install, so as patients are recording rhythms, they are flagged up to the service. You can pick up when someone's had a symptomatic rhythm detection, and you can get them back in, or you could remotely manage them. The reason we brought back patients in was to get the devices back on a lot of occasions. But obviously a lot of this can be done through virtual clinics. And this allows a largely undiagnosed patient population for sometimes for many months, and even up to a year. Sometimes we see people who have come to us who haven't yet been diagnosed, and it gives them the opportunity and control over monitoring their own heart health. Trudy's touched on the guideline already, so I'm not going to mention any more than that, apart from just to highlight a few things about it. Ours was only one study, only one trial that was included within the report. We knew already that Kardia is an accurate device. What this new collection of evidence shows us is that more people have AF detected using it. People have AF detected quicker. We know it's easy to use, it's compact, you can put it in your wallet or handbag and have it with you all the time. Equally, it can be used using an iPad at home, so it's very accessible, and we showed that patients found it very accessible and really liked using it. Talked about our cost savings. NICE has used obviously a lot more data there and has found it's cost effective. In a similar way to us, it's due to reduction in doing the wrong tests. So in summary, it's clear that technology such as this does improve the detection rate and time to intervention, picking up symptomatic rhythm detection in patients with symptomatic cardiac arrhythmias such as atrial fibrillation and SVTs, and it's cost effective. There are many models, ours is just one, which may be better suited in different environments in different areas, but most importantly, it gives the patient access to the correct test to make the diagnosis for the symptom with which they have. Thanks very much.
Thanks, Matt. So we've got a couple of questions, but what a great example of two completely different perspectives, as in one about early detection and one about treatment and the importance, symptomatic treatment, and the importance of doing this across the whole pathway. Trudy, there's a couple of questions for you, so I'm going to call them out and then come back to you, because there's one question I'll take and then there's one for you, Matt. So it's, I think you've answered this, but there was a question, are you saying that the Apple iWatch could capture paroxysmal AF or only the AliveCor? I think you've addressed that by saying the AliveCor is the NICE approved, but you might want to touch on that. And then there's two questions that I think probably, somebody wants to know how to start a similar initiative in their vaccination clinic. So what advice would you give them? And are there any resources they could use that, are available to help with that? And then something about some more about your insights into a bit more about what AF patient insights you've had from your extensive work with patients and communities, particularly regarding the reasons and barriers for why patients with AF might not be prescribed an anticoagulant. And this is from Patricia, who's reached out and said, let's speak. She's from the Stroke Association, so some good synergy there, no doubt.
Okay, so first of all, we have all the resources. We even have an SOP, how to set it up, what to do in vaccine, because we're now rolling it out, not just in COVID, but in flu vaccine centres as well. We've got over 50 centres doing this, and we are able to loan a limited number of AliveCor Cardias, as well as all the resources, the evaluations, the letter for them to take to their GP, the A to Z of how and what to do, and we provide everything. We've even got videos that can be played on screens in GP surgeries showing how to do a manual pulse check, how to use an AliveCor with subtitles, with volume, you name it, we've created it because of the demand. And we now have swathes of areas now. I was told yesterday there's another 11 GP surgeries coming on board in a certain area, and another 4 somewhere else, and 3 here, and everything. So we have all of that. If they just want to contact me, email me, and we can send it electronically, and we can also give you hard copies. Because even the important thing, even if you don't detect AF, you should still give somebody information about how they can manually take their pulse and what is AF, because they may not have AF today, next week, next month, but the chances are the older they get, they eventually will have a 1 in 2 chance of either having AF or looking after somebody with AF. So it's a great opportunity to raise awareness, but more importantly, to detect AF. So yes, we have everything and can provide everything. And speak to others that have rolled this out as well. So that's the first question. And the other from Patricia at the Stroke Association, yes, please contact me. And we've got lots and lots of patient testimonials, barriers accessing anticoagulation, which anticoagulation to access, which one's best for me, etc. And again, we have all those resources. We have an AF fact file. Everything we have is reviewed, written, approved by our medical advisory board, not just in the UK, but internationally. And Professor John Cam is our president. So yeah, we have all of those things. And we have everything for doctors as well.
Great, thanks, Trudy. And Matt, there's a question for you on how transferable is your protocol to somebody else's CCG, and do they need a cardiologist involved, and do you have a pathway they could use? And then there's one that's just come in that I'll just ask both of you to think about, is the difference between AliveCor and the KardiaMobile, because I think we probably use them a bit interchangeably, so one of you. But Matt, over to you on.
Okay, so I'll just touch the first one. Actually, the AliveCor and Cardio, they are the same device. I think they are the same. There's new devices that are the 6-lead one as well, but I think that's still called a KardiaMobile as well.
Sorry, Matt, I often get that question. I always say, well, AliveCor it's like having a BMW, but then there's different models, and the Cardia is a model of the ECG. That seems to explain it to everybody.
Thanks, Trudy. So yeah, our protocol is very transferable. I know lots of other places that have also now instigated similar types of clinics, and a couple of GP surgeries actually who have used it as well. It's always nice to have a friendly cardiologist on board for when you record rhythms that you're not entirely certain about. But all of the rhythms you record are atrial flutter, atrial fibrillation, SVT, reasonably easy to pick up. But when you get sort of something like atrial tachycardia and not entirely certain about it, it is nice to have a friendly cardiologist to send the ECG to, or just to take around to the clinic, for example. But there's no reason why this has to have a cardiology team involved with it. It is about detection of a rhythm, and then cardiologists don't tend to see most of these patients anyway. So out of the 290 patients that were referred to the clinic, it was only 3 or 4 of the patients with an SVT who wanted consideration for ablation, and the atrial tachycardia patients that we referred on to cardiology. So it's also reducing the use of the valuable resource of cardiology. And I know from speaking to them how many referrals they get with palpitation or with ECGs of patients who perhaps have palpitations or unexplained symptoms. So in our hospital, they absolutely love it because it takes away a lot of the work and referrals that they would otherwise have to deal with.
Great, thank you. And there was a question for me about, do I feel the current long-term plan refresh and the accompanying the HSC Bill Act provides sufficient support for this crucial aspect of prevention? This is, as I said earlier, I'm moving into a role where CBD will be under my remit from a digital perspective. And I have to say, from the people that I've met to date, I believe they will absolutely be ensuring it's very, very obvious within any LTP plan refresh. I mean, if I was to quote Shahid Ahmed, who's the National Clinical Director, on something the other day, he said why he comes to work is to save lives and to prevent cardiovascular disease. So I think there's a real sense of purpose now after COVID that we need to really up the ante even more. So I think that's definitely, it will get due attention. There's a question which truly might be best for you, the cost of the device and how people get it.
Yeah,
I bought mine on Amazon, but
yeah, I've just replied actually. I believe they can be bought on Amazon. We also have them to order on our website. And if it's a clinic using them, we may, under the Know Your Pulse, we may be able to loan them out as well. And they're less than £100 for the 1 lead. And there's also a 6-lead one as well. So for many people, they are affordable. And I say we can loan them as well. But some people, and this is not a promotion for the company, I'm just giving you feedback. Some people have said it's brought me so much reassurance. It's been life-saving. I've been going to my doctor and, he believes me, but he just can't seem to capture the evidence until I had an AliveCor Cardia. And I went, look, and I walked in with the reading. So I think that the simplicity of its use and it, it's really, really easy.
Great. Thank you. And I think we're going to run out of time, but perhaps, Matt, one clinical question here. Can it detect complex issues such as bundle block?
So the single lead doesn't, and in palpitations there isn't really a need for that, but the 6 lead certainly can pick up things such as that. I mean, it will pick up a broad complex, for example. I don't think it gives you the actual QRS complex, but it will give you a single lead. But the 6 lead obviously gives you more chance of picking up all of the leads.
Wonderful. Thank you both. We've actually overrun by a minute, but thank you. That's been a really inspiring session. I'm going to go and use my AliveCor myself later on. I've just decided after today you've inspired me to make sure we do it regularly. Yes, thanks again, and I hope it's been useful for everybody. And I think it's probably not the first we're going to hear on this really important subject. Have a good afternoon.
Thank you.
Thanks.